And Dr. Legron's not here today, so maybe Mike, can I ask you to come up on the panel, or maybe let's see who. Let's get Bill Lavelle. You're working on your talk. Bill, can you come on up to the panel? We'll get one more. Yeah. So what we're going to do now, and one of the points of feedback we got last year was to talk a little bit more about including cases, have some discussion, and we've got participants in this program who have got a lot of experience, and we can learn a lot from each other. I really value that. So what we're going to spend some time with now is going through a couple cases that I chose that I thought would be illustrative of some points that we make across the next sessions. The next session is going to be actually on anterior surgery, but I've got a spectrum of cases here, and I thought what we do is have the panel maybe talk about some of these cases. I'd really like to make this as interactive as possible, so we got microphones up here, and let's have some comments and some suggestions on this. Here's the first case I thought I'd show. I'll show you a scoliosis case, and I want to set this in the context of quite accurately. This is a 68-year-old woman. She's had progressive deformity to her spine. Now, she's actually a marine biologist. She spends half her year in the winters in Hawaii and the summers in Alaska and studies marine biology, and does a lot of hiking, does a lot of work in the water, but also getting to places, so a lot of walking. And she feels that she's had progression of deformity to the point where she's got her ribs abutting her pelvis and a lot of pain to the back that's limiting her. She's also getting some neurogenic claudication, and this neurogenic claudication's got to the point where it's actually outside the house. She's got to use a cane or walking sticks or some support. And subjectively, she feels like when she's walking longer distances, she's getting some subjective shortness of breath. I put in her pulmonary function test here, which we often do for patients with more severe thoracic deformity. We don't tend to do it in lumbar deformity. And then her DEXA score I put in here as well in terms of her preoperative risk stratification issues. So this was a woman who in fact presented with significant disability. But I'm going to change the scenario a little bit before I go to the x-rays. And in terms of not an uncommon scenario that I see, and is a patient who's 68, maybe 70 years old with maybe a stable deformity, who says, you know, doc, I'm worried because I'm getting older, but I'm able to walk miles. Again, marine biologist, and I can walk up and down the coast. I can get up into mountains, but I am concerned that as I get older, I get some aching pain in my back. I take anti-inflammatory medications on a regular basis. I'm concerned as I get older that you're not going to be willing to do surgery on me. Who has this scenario quite often? I see this every clinic, right? I find this one of the more difficult conversations to have. So I think the symptoms are a big part of what goes into our decision making, and I wonder, maybe Justin, do you want to talk about that in terms of symptoms? How would your thinking be different in somebody? I'll just show you. So here's her X-rays. She's got a lumbar degenerative pathology, but if she were to present and say, you know, I'm able to walk a couple miles, I take Advil every morning. I've got to stretch and exercise every day, but I'm able to get by with just Advil with some aching pain, and I can walk a couple miles compared to somebody who's got really severe symptoms.
Yeah, I think that's a great question. And, that's a great question, and I likewise face this question every day from patients. My standard response to these patients is, listen, we are not going to do any surgery until you are truly debilitated by this. There are maybe certain instances with myelopathy. I see a lot of skiers that have bad myelopathy, and so they might not have horrible symptoms yet, but we treat that earlier rather than later. Otherwise, in a case like this, I really urge patients to hang on as long as they can, especially in a bigger case like this, because most patients, if she's already that fit at 68, I think you could do her surgery probably for another 10 years safely, at least 5 years. So I ask them to really work on conservative measures, and we try to optimize their activity level. And if they're still getting around and they're still functioning, the potential disability after a surgery like this is huge. And so I'm very aggressive in continuing with conservative measures until they're really stuck in the house and they're not getting out and they're not doing much at that point.
I think this is a fabulous example. I actually had just this come in to see me my last office hours, but I'll make the setup even worse. So mine was a 68-year-old family practice doctor whose husband's a GI doctor. She came in because her husband urged her to come in. She's got mild Parkinson's disease. Her complaints were that she was stiff after yoga, and she wanted to know if fixing her scoliosis would make her any better.
Yeah, that idea of wanting to avoid being stiff with a multi-level fusion is a fundamental misunderstanding, I think.
So, Billy, you're fixing her on Monday?
She's booked. Yeah.
Big
That's
promises.
Right. That's right. Front, back, front, back.
And the other thing I would urge is, and I think my mentors taught me this when I did my fellowship, is never operate on someone the first time you see them with a deformity like this, because you really don't know how progressive this is. And so, especially in someone healthy like this, you have the opportunity of observing this over time. Yeah. And so getting a film in a year or two really does, I think, give you some additional information. The other is, when you were mentioning her symptoms, as an MIS guy, I may, if all of a sudden she starts becoming debilitated with her neurogenic claudication, I may just decompress her without fusing her as well. And especially if I have time points, radiographs over time, that her deformity is not worsening. So there's, you don't necessarily have to do the whole deformity every time you see someone with a adult degenerative deformity.
Yeah, I think that's a really terrific point, and really understanding the patient's symptoms, their presentation, and somebody who's got pure radiculopathy, somebody who's got primarily neurogenic symptoms with a stable alignment. And that was a big point in the paper we wrote about the appropriate use of surgery in patients with deformity, was in patients with a major sagittal malalignment and in patients with a progressive deformity. In general, we're not going to be very enthusiastic about doing a decompression only, but in a subset of patients who have a reasonable global alignment and who aren't progressive, then suddenly decompression or limited surgery becomes a very, very good option. So Billy, maybe you can talk to us a little bit about the alignment on this. Or go ahead.
So I was going to add this one, which is I remember you giving a talk that was a quality talk and a value talk that it depends upon where you're standing. So you showed a picture of, I think it was somebody who got with a procedure like this who had either an X-stop or a facet screw or something very small, and the question was this depends upon how you measure the where you're standing and measuring the cost versus benefit of the procedure. So in other words, and this is a fundamental question, right? So we don't know the answer. If you're going to do a big surgery that poses substantial risk and disability, is a smaller MIS procedure better? At the same token, if a patient's going to come back to have an additional procedure in 2 years, have you done them a favor? And knowing which patients to pick for what, I think, is part of the art of what we do now. So go ahead with your question.
Yeah, well to build on what Bill was saying is the notion of the perspective of the stakeholder, right? So on the one hand, you got the perspective of the hospital, where something small, maybe limited decompression, certainly limits the exposure, the risk to the hospital, the overall cost of care. And if you look at the quality metrics on that, in general, that's not going to have a high rate of 90-day readmission. It's not going to have a high rate of reoperation, at least within that 90-day period. It's going to probably end up going home, not using the ICU, limited resources. But having said that, if we do something that doesn't actually improve the patient's health status, that it becomes a patient and a physician who are really most invested in the notion of what happens 5 years down the road or what happens 10 years down the road. Yeah, so Billy, why don't you maybe describe what are you seeing in this deformity? This is
right. So the two components we see on the left is her PA X-ray, and you see a substantial lumbar and thoracolumbar curve. Coronally, she's imbalanced. That being said, her shoulders are pretty square. Looking at her from a sagittal profile standpoint, she has what appears to be a reasonable amount of lumbar lordosis. She's got frank thoracolumbar kyphosis, but while we don't have a sagittal plumb line, it's just by the X-ray hash marks, the grid that's present on the film, her head is reasonably above her pelvis. So In judging her, I would say that she's principally a coronal deformity in terms of dealing with her presenting pathology. As she has a thoracolumbar curve, that may change when she has a potential instrumented spinal fusion. We may make a sagittal plane deformity if we aren't careful when her lumbar deformity is corrected. So principally a coronal deformity to be dealt with.
So I think I'll add to that a little bit. I think this actually has got hash marks. This is one of our older films, and so quite usefully. And what's important here, I think, as Billy recognizes, this coronal deformity is her trunk is shifted towards the left, and importantly, that trunk is shifted ipsilateral to the thoracolumbar convexity. And I think it's probably familiar to most of you, but there are three descriptions. There's sort of an A, B, and C coronal deformity. And an easy situation is if the trunk is shifted to the right, and if I go ahead and correct that thoracolumbar deformity, then that's going to automatically correct the patient. And that's a really easy situation to make better. If I compress along the convexity of the deformity and maybe distract along the concavity and bring that trunk from right to left, then that's a simple coronal malalignment. In this instance, it's a little more complicated because if we take a look at the patient's actually shifted towards the concavity of the fractional curve. And what that means is that if I try and go ahead and do a major correction of that thoracolumbar curve, I can actually drive that patient even more to the left. And that ends up becoming a real problem and a real challenge because it's much harder to get L4 to S1 horizontal than it is to, in general, T11 L4 is much easier to correct than the L4 to S1. And in my hands, this type C deformity is one that I almost always go front and back on. I really try and horizontalize that L3, that L4, and dial in the correction across the thoracolumbar junction. So the one area I might disagree a little bit, Billy, is I agree that the C7 plumb line, so if you look at the markings, the hash marks on the X-ray, C7 is certainly within 4 or 5 centimeters at the back of the sacrum. Each of those hash marks is actually 5 centimeters. And but if you look at the pelvic tilt here, I think this patient's really got a really vertical pelvis. And you can't quite see it on the AP, it's cut off, but on the lateral, this patient's got a pelvic tilt of actually 32 degrees. And I think that she's compensating. I told you that she's 68 years old, but very athletic, very fit in general, and she's got good hips, so she's able to kind of retrovert her pelvis. So the global alignment of the spine, I think, isn't terribly far off. But if we look at our sagittal alignment parameters, I think we're going to have a talk on this during the deformity section tomorrow. We don't want to just look at the SVA or the sagittal vertical axis, but we also want to look at both the pelvic tilt, and a pelvic tilt in general, we're going to want to have that less than 20 degrees, maybe up to 25 degrees in somebody a bit older than this, but generally our goal is going to be less than 20 degrees. And so she's really retroverting her pelvis quite a lot. And then the mismatch of her lumbar lordosis to her pelvic incidence, I'll show you that. In general, I try and measure that on a supine X-ray. But her pelvic incidence here is actually 54 degrees, and her lumbar lordosis is down to less than 20 degrees, about 18 degrees. So I think there's both a sagittal and coronal malalignment here. But I will leave it with the caveat that she's got a stable deformity. What I mean is that although this has been, she says, gosh, doc, this has been really progressive. My ribs are down in my pelvis. It really hadn't changed much, and I had X-rays going even up to 5 years back. So here's the measurements I got. If you look at her SVA, it's actually a pretty reasonable SVA. It's just off by a centimeter, but her lordosis was 18 degrees. I guess I got these numbers off a little bit. So she's got about I'd say a 30-degree mismatch, right? If our goal is to have our pelvic incidence, lumbar lordosis with about 10 degrees, or our pelvic incidence is about 30 degrees off. And then our pelvic tilt is really, really quite high here. So I think she's got a bit of a coronal and sagittal malalignment. And then just kind of dialing into this a little bit, and Jim, I'm going to get back to you on this next question, is what about the role for decompression here? So I'm just showing you more of a close-up. I think I'll show you some more advanced X-rays and CT scans. But when you see this kind of rotatory subluxation of L3 on L4, some lateral subluxation of 4 on 5, and if I were to say, she's really got a lot of left-sided radicular pain, left L4, left L5 is giving her a lot of pain, maybe some central stenosis at 3-4. What's the limit at which you think, even using MIS techniques, that you can really do a decompression? How much oleocesis or how much lateral subluxation is the limit where you'd say, I really can't safely decompress that without taking the risk of a progressive deformity?
So Sigurd, I'd like to probably see a CT scan on her and an MRI. I've gone to getting both studies on almost everyone, and also her bending films are, so to take a step back, if you look at her bending films, you can see that she's got this vacuum phenomena, so that L3-4 segment is unstable, no doubt. And then on the CT scan, you can also see the vacuum phenomena. So once I start seeing that and they're highly stenotic, I would be more concerned about decompressing her without fusing her at those segments in general. I can say, though, that if I am going to decompress, I keep all my midline structures intact. So I do a laminotomy type approach, and through that laminotomy, I can do bilateral decompressions with the MIS technique. So I would absolutely keep the lamina intact, the spinous process intact, the interspinous ligament complex intact. So try to give as much of her natural stabilizers intact as possible. But with that said, with these images, if I had to decompress her and think that I had to start resecting her facet joints for the decompression, or at least partial facetectomies, I would probably fuse those levels. And I would fuse it with probably a T-lift type of approach as well, MIS.
Right, and just to also kind of, because we keep having a moving target as to our patient's symptoms, right? Just to
intentionally, I think.
Right, I think so, because we talked about what's her complaint, and then we went and we said, well, her sagittal deformity may be an issue, and I had cited, well, maybe it's not an issue. I mean, if she's not really complaining about substantial enough sagittal deformity, coronal deformity complaints, I think it's a reasonable thing to consider doing something focal. That being said, like I cited earlier, I think it's an unknown to us. Will something more focal burn us in the future? Like, I wrote a paper with Doug Orr that looked at similar patients with degenerative deformities that had focal fusions. And one of the things that came up in our paper was that if they had decompressions that extended above the area that they were fused, like you're citing, taking down midline structures, that they tended to go on to have additional surgery. So, I think to focus the complaint, if she's principally complaining of radicular pain, and she's not really complaining about a deformity issue, I think it goes to that argument of, is something short and focal meaningful in that we won't be back, or at least won't be back in a reasonable value-based amount of time, or do we do something more comprehensive? And if we're going to do something more comprehensive, boy, it feels better leading people down the road of a procedure that has a high rate of complications if they have more complaints, right? I mean, if they have complaints of radiculopathy and stenosis, and standing difficulty, and measurable qualitative changes that have affected their lives from their deformity, it's a bit more reassuring as the person leading them down the primrose path if that disease burden is substantial enough to justify the intervention.
Yeah, certainly there's an opportunity for some improvement. Jim, in terms of, so I am changing the scenarios intentionally, because if I had said this is a progressive deformity, she's now got her ribs in her pelvis, Jim would not have been willing to talk about his MIS approach. But what I wanted to get you to talk about too, just briefly, Jim, is I said it's left-sided radiculopathy. So if it's left L4, L5, and maybe some such stenosis at 3-4. Are you going to approach this? So I really like how you described you're going to leave your midline structures, you're going to go up from one side and then decompress the opposite side. And I actually do a bit of a laminoplasty on that. But which side are you going to approach this from? If it's left-sided radicular symptoms, are you going to approach this on the right or the left?
So if you go back to some of the axial images real quickly, Sig, so I can tell you that it's going to be much easier to go from the right-hand side on this patient because you can, again, get your decompression bilaterally. And if you take just a small amount of the spinous process, you can go over the top of the dura and really very easily do a foraminal decompression. Yeah. actually foraminal decompressions are much easier contralaterally than they are ipsilaterally because you can use straight kerosins instead of foraminotomy kerosins. Now, with that said, that's if I'm just decompressing. If I was going to decompress and fuse her, I would probably do a facetectomy on her left-hand side to restore as much foraminal height with a T-lift as I could. With that said also, when you operate on people with radiculopathies, I tend to go from the side of their radiculopathy because a bad case scenario is they still have a radiculopathy postoperatively on the ipsilateral side of their symptoms. A worst case is you've created right leg symptoms. Now they're like, wait a second, I went to bed, went to sleep with left leg pain, now I have bilateral pain. Or, so I try to stay ipsilateral as much as I can with the caveat, if you were just decompressing the foramen, I would probably go contralateral.
Yeah, so I think this is an important point that Jim's making. It's a lot easier to kind of reach across when you're going from a unilateral approach. It's a lot easier to reach across, take out that superior articular facet. You're looking right at it, and with your straight instruments, you can get across. To decompress the ipsilateral side, so to go from, in this case, the right side, which is the left side of that CT scan, but to go from the patient's right-hand side, it's really tough to get back at yourself without taking out the facet joint. And now you're on the concave side of the facet joint, so that's going to collapse. And we had designed a device that was meant to be used for that. It really maybe hasn't been as popular as I thought it would be. But have anybody seen the Baxano device where we kind of shaved out the facet joint? And sometimes I'll use that to try and get the ipsilateral side. But I've definitely taken towards your approach of reaching across to get the more stenotic side. So let's move on to a little bit. And maybe Justin, Jim had said, maybe you would do a limited fusion, so recognizing the fact that there's a vacuum disc at 4-5, central stenosis at 3-4. He was concerned to some extent about maybe having to take out that because of the up-down stenosis here at 4-5. He thought he really would have to take out a good bit of that facet joint to really realign that, so he wants to do a T-lift there. So what can we do for a limited fusion here? What levels would you be thinking about? Maybe everybody could address that. So again, we're going to make the scenario now, stable deformity, really hasn't progressed much, and she's not bothered much by the fact that she's got a hyperextender hips. She's able to get into a global alignment with a stable deformity with reasonable compensation. So how could we do a limited approach on this?
I think the most important thing here is to approach the levels that are stenotic, like significantly stenotic. Yeah. And so, there's a little bit more of the picture. So I would imagine typically in these cases, the L3-4 and L4-5 would be the worst, where there's that much lateral listhesis. So at a minimum, you'd want to fuse those levels so you could do a really complete decompression and stabilize those levels that are slipping laterally. Then you're faced with this question, though, that the top of your construct is right basically at the apex or close to the apex of that curve. So then you have to debate about whether that's going to progress as you do a fusion. And that's always a tough question. I have a series of cases where I've done limited decompressions and fusions on curves, and most of the time, in my experience, they stay fairly stable. I have seen some progress, but most of the time I have not had to go back in and operate. So I think that can certainly work. In this one...
So let me now give you some more information here. Then, just to, I like what you're saying is you're worried about stopping a fusion at the apical vertebra. And so 3-4's got this central stenosis here. She's not terribly stenotic actually above there, and she's kind of got a bit of a vacuum disc at 3-4, at 2-3, but maybe some osteophytes there. But 3-4's got this pretty severe central stenosis. And here on the, again, this is the right side on the MRI scan, really tight on the right side at 4-5, and really tight on the right side at 5-1. Okay. So are you thinking 3-1 here, or with T-lifts, or?
Yeah, at a minimum, but this is one where I might extend up a little bit farther, just because you are seeing, like you said, that vacuum phenomenon at 2-3. That is right at the apex. You know, I think when there's a curve that's less subtle than this, I don't worry as much about that apex. But I think if I ended a fusion right at that apex with this curve, I'd be a little bit nervous. So I'd probably go up a little bit higher.
So 3-level T-lift?
No, I'm saying I'd probably go up higher than just doing those 3 lower levels.
So go ahead. Why don't you tell us what you do then?
So in this case, probably go up to T12, L1. Again, I will backtrack for 1 second. If for some reason I was concerned about some health issues or something like that and just doing a focal, then I would do 3, 4, 4, 5, and 5, 1, and then we just keep a close eye on that apex.
Yeah, so I think in general, maybe a conventional approach here would be to go from a neutral, stable vertebra, and if we get up to T12, it's kind of getting towards neutral in rotation. You look at the Harrington central sacral line, I might even lean towards even a little higher than that, but probably getting towards a neutral, stable vertebra and above the apex of that deformity. Please. Yes.
We're all thinking about this like deformity surgeons. Your first AP x-ray was rotated, so you can see that the pelvis on the patient, it's not a direct AP on that film. That's the first thing I saw. Clearly, not enough lumbar lordosis. So all of these discussions about doing T-lifts, you aren't going to correct that lumbar lordosis very easily with a T-lift. Unless you...
Right, but that's not her complaint. Her complaint's ridiculous.
No, I'm just making points. You won't correct the sagittal balance probably with a T-lift unless you take off the facet joints and correct it that way. If you're going to do a fusion for this case and you're hoping to get rid of back pain and you leave L5S1 out or L23 out, you won't get rid of their back pain. So you're basically now talking about a T12 to the pelvis fusion in a lady who's very active. And we've just talked about the complication rates between 30 and 50%. So I'm going to get booed out of the room, but I would present as a shared decision-making option a spinal cord stimulator.
Boo, no.
I'll tell you what, here's what I'd tell this patient. I would do a perm trial. I'd put the top of the paddle leads up to T7. If she came back and said, you know, doctor, this has completely relieved my back and leg pain, I'd bring her back the next week and put in the battery, and I would have saved her a T12 to the pelvis fusion. She would continue to be active, and if it doesn't work, you haven't burned a bridge. You can still go back and do a big surgery.
I'm glad
but why don't you offer that?
Yeah, I'm glad you brought that up, and I can tell you this is several years ago. I never even thought of it, never heard of it, never knew anything about it, but the last 3 years I've spoken to North American Neuromodulation Society, and I think and you gave a nice talk last year.
I did 200 of these cases in the last 3 years. I haven't had a failure. And if you present it to a patient who's already active...
So again, I don't believe that, but let's move on from there.
Complication rate's low. Complications rate low. It's outpatient surgery. No significant risk. No blood loss. They're walking. They go home the same day.
So I think this belongs
why wouldn't you present this to the patient? Because they have nothing to lose.
Yeah, this belongs in the discussion. I agree with you, and I think we've got a group of our pain management physicians who are very enthusiastic about neuromodulation.
Let them do it. Do it yourself.
And, yeah, that's not going to happen.
Then you're not a complete guy. Offer it. Do it yourself. Do a laminotomy. Put the lead in. It's so easy.
Yeah.
And why would you rely on a pain management guy who's not going to do it that way? He's going to put in percutaneous leads, and then he's going to take them out, and then you're going to ask him to put them in exactly the same place. This is a technique that should be done by spinal surgeons.
Yeah, so I completely agree with the idea of let's not have so many silos and actually integrating silos, and that's the notion of what you get depends upon who you see. And if you see my pain management doctor, you're definitely going to get a pain stimulator. If you see, but I think the notion of crossing those silos or building bridges between those silos is really important, and I completely agree that this is worth bringing up as part of the discussion, is some alternatives. CBD becomes a big discussion that I have no idea how to talk to people about CBD, but that's something that I have people talk to, people who know about that. Dorsal column stimulators, it's something that we ought to know more about, and that's where trying to bring together multiple disciplines working together is a big part of that. So having our pain management doctors talk about alternative pain medications, there's a lot of very interested opiates and non-opiate substitutes now. So we'll get off of this topic now, and I'll just show you briefly. I was going to say Jim was part of an interesting paper looking at limited fusion versus more extensive fusion. Showed that the highest patient satisfaction in adult scoliosis was actually limited fusion, but the improvement was actually better with more extensive fusion. So wrapping this up, what I ended up doing, right or wrong, is I ended up going 3-to-1 anteriorly, kind of horizontalized L3 as much as I could, got some lordosis there, and I ended up going to what I thought was a neutral stable vertebra, which was T10. And you see, I didn't actually completely correct that T10 to L4 curve, but rather kind of dialed in enough correction to give her global alignment. So I bring this up as the first example because our next topic is going to be Jeff Deckey's going to show some cases of anterior surgery. And in my hands, these cases where the trunk shift is ipsilateral to the fractional curve, to the concavity fractional curve, are really tough. And I'm just going to show you briefly a failure of that. So, well, here's another example. Again, trunk shift to the left and that fractional curve. And again, I did it front and back, and I was able to get that well aligned. But here's one I didn't do very well. And this is a pretty straightforward case. But a woman of similar age, I had already done her cervical spine front and back. She had pretty severe cervical myelopathy. She actually presented with lumbar degenerative symptoms, radiculopathy, stenosis, deformity, shifted towards the left, and she was grossly myelopathic. So I did her neck first, and generally I try and give people at least 4 to 6 weeks after the neck surgery before I address the lumbar deformity. But here's one, it's a real failure that I'm embarrassed about, but I'll share with my friends. So you say, I just showed a couple examples, and I virtually always, I go 4-to-1, I use the nice, peak HA cages, and then get that horizontal and just dial it in from the back. What I ended up doing here was I tried to do this with T-lifts, and you see the gross failure here where I left this patient too far to the left, because in my hands, getting that fractional curve from 4-to-1 to correct can be really challenging. And in fact, Larry Lanky, I got a lot of respect for his work. He showed that 2/3 of the cases, actually, Larry didn't show this, Maurice showed 2/3 of Larry's cases ended up left where the trunk was shifted ipsilateral to that fractional curve, done all from the back. 2/3 of them stayed over to the left. So I think this is a real strong argument for an anterior surgery. And I know Jeff is going to talk about that next, but I thought I'd show these cases as an introduction to that. I think we've got about 10 more minutes before Jeff's going to come up, so I'm going to maybe show one other case, and it's not going to be this one. This one's not very interesting. It's not going to be this one either. This is we might get some of these later. I'm going to show a case of more of a limited fusion. We've got plenty of cases we can go through here, and over the course of the days, maybe we'll do some of these. All right, so here's one. 64-year-old. She's a realtor up in Napa, and she is had a long-standing scoliosis. In this case, it's been a real stable scoliosis, no progression of deformity. She's got left-sided radicular pain, L4 and L5, and she's actually had 2 attempts at limited decompressions, both done from the left side. So again, 64-year-old realtor. She's a golfer. She plays golf for, not at the LPGA level. She plays at her local country club, but it's a big part of her life. She's had left L4 and L5 radicular pain. Here's her standing films. She says, Doc, I've known I've had scoliosis since I was 30 years old, but it's never really bothered me. I play golf actively, but this left leg pain's got to the point where I got to take the cart to get around. And again, 2 prior attempts from the left-hand side. She had 2 laminar foraminotomies done. Here's just more of a close-up X-ray of what she looks like, and I think I've got the MRI scans here. This is 4.5 and 5.1. You see there's left-sided foraminal narrowing at both 4.5 and 5.1. So this time it's not backwards. So who wants to start off on this one? We only have 7 minutes and 30 seconds, so somebody...
I'll jump in. So this is one where, back to our previous discussion, and someone that active who's still, how old was she again?
64.
64, so fairly young, really active. I would talk about just a decompression here, micro decompressions on that left side, and just say, hey, you may need a fusion here before too long, but as active as you are, let's try to keep you out on the golf course active, doing all the things you like to do, and hopefully take care of that leg pain so you can keep walking. You
Yes,
don't have to jump in the
that was
golf cart.
tried twice now. So twice she had 2 laminar foraminalitis, 4-5 and 5-1 twice, and it didn't work. And this is
can you
actually
put back
where I
on
think
the
there's
MRI?
the best evidence for exactly what you're talking about is for if you're going to decompress, the subset of patients with recurrent stenosis symptoms have got the best evidence for neuromodulation. As a subset of patients who have had prior surgery, still have radiculopathy, actually in a randomized trial did better than patients who had a revision decompression. Go ahead, Jim.
So it looks like she's been decompressed from medial to lateral. So another option is a lateral to medial approach.
Yeah.
At both levels, L4-5 and L5-S1, because it would be nice to see the sagittals in the foramen. But as we all know, foraminal stenosis at those levels is primarily arthropathy of the ascending articular process. And that the best in my hands, other than what I mentioned earlier, going over the top of the dura, the secondary best way of addressing that is from a lateral to medial approach. So that's another option for her. If she was absolutely 100% against a fusion, I would say I could try this. It may or may not work, and then you're pretty much your other option is a fusion.
So she has sciatica, like that's her
Yeah.
complaint as compared to having pain in her quad or
Yeah,
like that.
there's very, very, very much left L4 and L5 radicular pain, not a lot of back pain. And let me build on what Jim said. I think this is really important.
And can I just mention one thing real
Yeah.
quickly? With my technique, doing it MIS, even at 5-1, you can do it. It's not difficult. but
lateral
if-
towards medial.
Absolutely. And the one last thing is, I will always do that, even primarily, if the foraminal stenosis is in the lateral half of the foramen. So the more lateral you go, the easier it is to get from lateral to medial. So anything from 50% lateral, I will take care of from a lateral to medial approach.
Yeah, well, let's just give you some comments about that because, first of all, I find that really difficult at 5-1, and I really worry about getting too narrow on the pars. As I've seen plenty of people have had decompressions, and I worry about getting the pars fractured there. But I've talked enough. Charlotte.
No, just a quick question. She comes to you, she's had 2 prior surgeries. She says, I want one more surgery, that's it. I don't want another. I want a third surgery.
I tell her she's too hopeful. She'll have another surgery in her life, but
No, but yeah, I mean, that's the kind of comments patients say all the time.
I would say then a fusion is your best option to at least not have surgery at those levels, right? But at the other levels, you just can't promise anyone that they're not going to have another surgery.
I think you said her primary real-world complaint is that she has to take the cart rather than walk off first.
tell her to take the cart.
What is a 3-level fusion going to do to
Is it a 3-level fusion now? Also, in terms of if we're doing a multi-level fusion, we talk about how many levels, but suddenly are we really protecting? We published a paper recently looking at patients with spinal stenosis who either had decompression alone or decompression infusion, and revision surgery rates were exactly the same. In 3 years, it was actually 30% had a revision surgery, and it didn't matter if they had a fusion. So I'm not sure if by doing a fusion we're reliably saying you're not going to have another surgery. Let's,
Discussion about expectations. And, we want to please our patients and do what they accept, right? And I look at my colleagues where they're shoulder surgeons and knee surgeons, and they have arthritis, and the patient goes, I want to run. And he's like, well, you're not going to have a knee replacement. You got to run an arthritic knee. And at a certain point, you've got to talk to the patient and say, I'm not sure I can achieve you playing golf with 2 failed decompressions and a scoliosis there and try limited fusion. Now, I always say to them when I try to do something less than more is that sometimes that less can lead to an immediate failure where we have to do more. Are you ready tomorrow, if we do a limited fusion or limited decompression for that matter, and your symptoms get worse, to go T10 to the pelvis, and that's a much bigger fusion, and are you really ready to commit to that today? If you are, then we can try something less and it may fail and we can do it tomorrow, the T10. But I think sometimes we have to start taking control of the conversation with the patient and tell them that sometimes your expectations aren't reasonable. I had a woman that had a similar curve, bigger curve, but severe stenosis. She's 70, big hiker, skier. Her hip abductor was completely out from the fractional curve from up and down L5 foraminal stenosis, and she wants a limited decompression. I said, she wants to get back to that. I go, you can't even walk. You got a Trendelenburg gait. That's probably not even going to come back. You're worried about getting back to competitive skiing. I said, we have to be realistic here. So I think we need to learn as I get older. I'm a little bit better
Just
Back to just the decompression versus the fusion piece. If someone's got side bending, quick reproduction of their pain, I'm really worried about another decompression without thinking about it. Because it tells you just collapsing that frame.
Yeah.
So whether that's approach from the back or front, side, or completely, it just tells me that.
that's good provocative test, please.
Yeah, I think for this lady, 2 prior decompressions, L4, 5, 30, 15, doing A-lift at 4, 5, and 5. Leave it at that, address the leg pain, do that as a leg pain operation, and it's basically your foundation to come back to address the first down the road. Get
Yeah.
burned in bridges doing that.
Yeah, that's one of my favorite approaches. I agree with that. And what about, well, if you say 4, 5, 5, 1, what do you mean at that rotatory subluxation 3 on 4?
If she's asymptomatic, I was going to reach out. If you're going to go after that, for instance, you're going to have to go after the rest of it.
All right, so last minute here. One more question for Jim. In a setting of 2 prior decompressions, how do you feel about going lateral towards medial on a third decompression? Do you worry about the scarring there and dural tear? And in my hands, that's one where when I go lateral to medial, the reason I'm lateral is because I took out the whole facet joint, then I'm coming lateral towards medial to get into a fresh plane. But if I'm just decompressing without taking out the whole facet joint, I worry about getting a dural tear.
So I would absolutely, if I were even to consider doing another decompression, I would get a CT scan first to make sure I have enough pars that by me resecting some of the lateral pars, I'm not destabilizing her. Because I agree, she's already kind of acting like a unstable spine. When she stands, she has her symptoms. When she sits, she doesn't. So she's probably not the ideal candidate for a third decompression, but I was just playing devil's advocate.
Yeah.
But if I were to do that, I would get a CT scan, and then the nice thing about lateral to medial is that you're not encountering scar until you get medial enough that you feel that you've adequately done your decompression. So I would still probably give it a try. And I can tell you, transitioning from open surgery to MIS surgery, if you do it through a tubular retractor system, even 5-1 is relatively easy to get at. You just have to make your incision far enough lateral, essentially right over the PSIS.
I think a really important message Jim gave that I agree with is anytime somebody's had a prior decompression and I'm thinking about another decompression, I always get a CT scan because it's not uncommon to see that the whole facet joint's gone. So,
They did not decompress her.
Very well.
yeah, yeah.
Well, they might have when she was supine
I just go there.
or semi
You
prone.
know that, you tell the patient that. Why not go medial lateral?
Yeah, I think what I was trying to show here is that there really is some up-down foraminal stenosis, and that was there's too much structural problem with up-down foraminal stenosis that wasn't going to get well decompressed with another decompression. That's what I was trying to show. I should have showed a better parasagittal T1 image. So let's take a quick vote then. This is our last thing. Decompression alone. So try another decompression, either lateral to medial or just doing a better decompression. Who wants to do that? Decompression with a limited fusion, so 4-to-1, 3-to-1, limited fusion, trying to avoid fusion the whole curve in a golfer.
And laying a lot of crepe that she may be back.
Okay, and then T10 or lower thoracic down to the pelvis. Who wants to take care of that one?
She has no back pain.
Yeah, back pain is really not a problem. Yeah, but she says Charlotte says she says I really want to have this be my last surgery ever. I can't tolerate another surgery. So I really want to have my last surgery. T10 the pelvis, anybody? Still can't tolerate. Yeah, very, very good. Yeah, I agree. So anyway, here's what I did. This is actually on the OR table. And the reason I show you this is I went 4-to-1 in the front. I was worried about that rotatory subluxation at 3-4. So I actually took the concave side, that left side, and I pulled that left-sided screw up out. I derotated her intraoperatively, and that's what she looked like on the OR table. And again, this is on the OR table. And what I said is, I don't know how high I'm going to go. I'm going to take a look at what I can do with 3-4. And if 3-4 is really rotated, and if I can't correct that, I'm going to probably, I talked to her about going up to T11 actually. And but that's what she looked like on the OR table. After surgery, she definitely kind of collapsed a little bit off towards the right a little bit. But she's actually, this is over 10 years ago. She, less than a year after the surgery, went back to her golf club. Again, she's not an LPGA golfer, but she won her club golf tournament, which I don't think she would have done with a T10 or T11 S1, but she was able to get back to golf. And it's certainly not a perfect result, but in her case, despite that adjacent level being a little bit off, this has lasted over 12 years now. So I'm a big advocate for trying to do less in some of these cases, as long as it's not going to the apex of the deformity.
Right, and I think we said another thing that was is it's about expectation. So if you have heart disease and you see a cardiologist and you get a stent, they don't pat you on the head and say you're never going to come back. They tell you you're most certainly going to come back. You see a joint surgeon who does your hip. I mean, they lay a lot of crepe for you coming back. I think if you do this, I think you have to lay crepe no matter what you do, that there's a good chance she's going to come back. That's her disease. I mean, she has degenerative lumbar scoliosis, and that's her disease. She'll always have it. And all our interventions do are optimize her and try to give her as much quality of life as she has for as long as we can.
All right, well, terrific. Let's thanks to the panel for your contribution to discussion. What we tried to do there is just show some of the variability of what's done, and again, prioritizing the patient's preference over being dogmatic.